So we built this really cool tool that'll help you figure out which peptide therapy best matches your personal history, medical history, medications, family history, and it also screens for low testosterone and menopause symptoms where appropriate. We'd already filmed a full-length video with the idea of chopping it up into different pieces to put into an ad, but then realized that someone that's curious about peptides may just want to see the full-length thing on YouTube too. So I threw the outfit back on and we wanted to film this intro. And this way we could explain a little bit why the tone may be a little different than our usual content. I also described why experts like Dr. Andrew Huberman and Dr. Craig Conover were recently talking about peptides and insisted on anyone who's interested working with a physician or other medical professional, as well as knowing the source of their supply here to make sure it's as pure as possible, not tainted with different bacteria fragments and those sorts of things. So it's as safe as possible in an area that's already not fully well understood right now. I even threw a little bit of shade at one of the major suppliers who had refused to send us their independent lab testing of their samples because it's kind of weird that they wouldn't do that. I also revisit a personal experience from a couple different videos here of really fast recovery after a hamstring tear and how peptides help that a little bit too. Now, if you already know what you want, go down to the description, click on the link there, and you can take your quiz right now, or just go to peptides.admiremedical.com for that same quiz. As of this recording, we're not even making you put in an email address or name or anything. You can just hop in there and have fun. Finally, there are disclaimers everywhere, but I gotta say again, this is entirely for educational and entertainment purposes only. It is not medical advice. Your results in the quiz are not medical advice. This is just so that you can see what sorts of things may be worth speaking with a professional about, whether it's your own physician or you schedule with Admire Medical. Either way, we just want to make sure that we're doing this safely because there's a lot of people going online and getting these peptides shipped in from overseas and not really knowing what they're putting into their bodies. I've helped thousands of men reclaim their vitality through testosterone therapy. And now I want to help you find a safer way to access peptide therapies. They've got a point. Peptides show incredible promise. I mean, retired athletes coming back to the sport they love and setting new world records. Current athletes returning to play after an injury unbelievably fast. Weight loss, vitality, heck, just the potential for some darn good sleep. Hamstring tear. But look at me now. Not years later, not even months later. This is about a month after I tore my hamstring in 3 places. There's a reason some of these peptides are named things like the Wolverine stack, racehorse peptide, exercise mimic, sleep peptide. Not really very creative on the last one there. And then other exciting names based on their effects on the body. If they're so fabulous, then why aren't they in the drinking water? Well, as small proteins, they need to be injected so they don't get digested by your stomach and intestines. And that brings us to point number 2. Even though it's kind of figurative there with the drinking water thing, the sources for these right now, most of the time, they're not rock solid, no doubt in my mind safe, which is kind of important because you need to inject these into your body. Certain sciences websites that can't help you figure out what's safe for you, they force you to do your own research, guess what's going to work best with your own biology, then blindly trust this bottle that a faceless company mails you in the mail so that you can inject it into your body. Plus, how do you know which one would even be safe with your own personal medical history and medications that you're taking and everything like that? Well, we solved all these problems. If you're already sold in the promise of peptides, you need to be sold in their safety. For the investment that you're making, in the very personal way that peptides are administered, you want to put your mind at ease. An ease that only a medical professional sitting across from you can provide. Let me show you the form that we just built that you can plug in your medical history, medications, goals, and receive a rank ordered list of potential peptides that you may want to look into. So I'm going to go through a quiz here and see which peptides might be a good match for me. All right. So my goals: build a little bit of muscle, recover better from my injuries, aches and pains. Sleep's always a good idea. A bit of brain health. Okay. Get my age in here. I'll say the end of 6 foot. Say I'm concerned about testosterone, and I'll say I'm taking in clomiphene and ibuprofen for those aches and pains. All right. No. Family history of cancer. No. All right. So because I had some concerns about testosterone levels, it went ahead and put in the ADAM questionnaire, which is the main screening test for low testosterone. Let's give it a positive test results here. Okay. All right. Of course, these are not approved by the FDA. All right. So up top here, you have your biographic information. Gives you a nice little summary there, including your highest priority goals. It mentions that positive screen on the Adam questionnaire, so you want to seek evaluation for testosterone levels from a qualified professional. This next piece here is going to explain how your score is calculated because each of these are ranked based on your answers. It takes in your priorities and health information as well as which priorities were not met by this particular peptide. So it subtracts points there to give you the best match. Some dosing protocols, some personalized notes here, and labs that might be beneficial to be tracking along with this one. So since I mentioned I was taking ibuprofen, it gives you a little personal note here about how this may theoretically offset some of the risks of ibuprofen on collagen production in the body. Now, to not overwhelm you, it's going to give a top 3 matches here, but you can see the whole list down here. In this case, because of that family cancer history, you can see that some of these growth hormone related peptides got knocked down lower on the list. All right. So once you're finished reviewing all of these, you can go up here and you can book that consultation with a qualified professional. Select yours truly. Got some times available so we can talk about this. But don't forget to save your results here because we're not going to save your data. We don't want you to feel uncomfortable about your health data floating out there. So this is personal for you. Visit peptides.admiredmedical.com. Take your own quiz right now. Peptides offer a lot of exciting opportunities for health, wellness, and physical performance. But as we said before, they're not FDA approved. And a lot of this kind of preparation is going to be making you feel more comfortable with some of the unknowns when it comes to these different peptide therapies. Hello, friends. My name is Dr. Alex Watson, and I decided to make this video on a whim because my soapbox, I just had to lug it out. Seeing the same things over and over when it comes to managing testosterone. So let me tell you about my background and why I'm qualified to possess such a soapbox. I have treated patients with low testosterone every day, 7 days a week for the past 3 months, and then 5 or 6 days a week for the preceding 3 months. So I've got my reps in. And there are a number of important things to think about when you are going to your doctor asking for testosterone. So, starting from the top, when you go to ask your doctor for a test on testosterone, tell them about your symptoms. Tell them that you looked at the Q-Adam or the Adam questionnaire, and you recognize that a lot of those symptoms actually are exactly what you're experiencing. Typically, these are going to be low energy, the standard I fall asleep on the couch right after dinner, like home from work kind of thing. But the most specific symptoms are going to be low libido or erectile problems when you didn't have them before. Bonus points if you don't have any cardiovascular disease, because then the erectile problems are probably not from blood vessel issues. Then you're going to get your blood tested. If they only test your total testosterone, ask them to also test your free testosterone. Or ask them to test your SHBG, your albumin, and your total testosterone. Get an estrogen or an estradiol in there too. You're also going to want to get a PSA. And while you're at it, a luteinizing hormone, LH, will help your doctor to figure out where the heck that low testosterone is coming from. Real quick when you get your labs back. Important data points. The total testosterone is not the most important number. Why is this? Because a lot of it is bound up and can't actually stimulate the receptors that you want to be binding to. Instead, that's what the free testosterone matters so much. Free testosterone is just floating around there and has a chance to actually do what testosterone does. It binds to the androgen receptor. Here's the interesting part, though. It is not the only player in this picture when it comes to relieving those symptoms. Estrogen is really, really important, and that's why some of the old prevailing wisdom of let's block all that stuff because we're men, we don't need women hormones, actually was probably incorrect. Nowadays, I don't suppress estrogen unless we really, really have to. In most cases, it's actually going to help relieve some of the erectile issues, some of the libido issues, and it'll offset some of the cardiovascular disease risk of bringing your testosterone up. So, interpreting your labs. You want to look at the total testosterone, but really the free testosterone. It's going to be in different units. If you go to a primary care doctor or a VA doctor, no shade here, but this is my experience, who doesn't do this all the time, they're going to look at that range and say, you're at 300 total testosterone, you're good. You're in range. That's not usually optimal, because oftentimes at 300 total testosterone, it's going to correspond with a 4 or a 5 on the free testosterone. If you're in the reference range here, there's a big gray area right in the middle where symptoms really matter. The reason why it matters is because everyone expresses different numbers of androgen receptors with different sensitivities to the testosterone. So your 7 is different than someone else's 7. Because of that, you really want to look at this in the context of your symptoms. And that's what your doctor should be doing too. The next piece, the estradiol. That's the main estrogen in our bodies. And you actually want this to be somewhere in the middle of the range. Unless you are already over the edge of the range and likely having estrogen side effects, such as nipple sensitivity or a lump development under the nipple or yada, 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 real gynecomastia, so breast development. Unless you have those symptoms, don't empirically start an estrogen blocker like anastrozole. It's also known as Arimidex. These often cause more problems than they solve because you'll reduce your symptomatic benefit, you'll increase your risk for cardiovascular disease, you'll reduce the muscle benefits, potentially putting you at risk for tendon injuries, you'll increase the risk for neurotoxicity if your testosterone gets too high because estrogen helps to balance all that stuff. There's more to it than that. So if someone says, we're going to start you on testosterone, and because of that, we're going to start you on an estrogen blocker, ask them to explain it a little better for you. If they don't have a good reason, say that you would likely like to decline for now. Or if it's not an expensive prescription, fill it and have those just in case you do develop some of those side effects. PSA. So your PSA is a screening test for prostate health. It's way too in-depth to go into right now, but our primary concerns about testosterone and prostate cancer have evolved into it probably doesn't worsen prostate cancer risk. And if it does, there's an argument to be made that those types of cancers are actually going to be less aggressive than one that grows in the context of low testosterone. That being said, it's still kind of poor form to give you testosterone if we haven't looked for prostate cancer and treated one if we found one. So in most cases, we're going to get a PSA, and if it's elevated, we're going to hold off on testosterone and do a little more in-depth PSA testing and then refer you to a urologist if you're not seeing one already. Luteinizing hormone. That test doesn't tell us where the problem is coming from. Luteinizing hormone is a hormone produced by your pituitary that gets told what to do by your hypothalamus. Your hypothalamus is listening to your bloodstream and trying to figure out exactly how much testosterone and estrogen you have. When it thinks that those numbers are too low, it tells the pituitary to tell the body to make more testosterone. The pituitary does so by raising or lowering luteinizing hormone. When it raises luteinizing hormone, that should equate to low testosterone levels because the brain is seeing that your levels are too low. However, there are cases where both are low. That tells you the problem is coming from the brain. If it's very low, it may be something like a benign growth called a prolactinoma. This is a benign growth of the pituitary that releases a hormone called prolactin. Prolactin can suppress your hormonal levels, causing other problems. If it's just kind of low, this usually doesn't have any one singular cause. Oftentimes, this might be a mix of things like metabolic syndrome. So if you have a higher BMI, fatty liver disease, that's going to be contributing. Poor sleep quality, stress, overtraining in the gym, etc., etc. If those are the cases, some doctors will say, fix that stuff first before I give you testosterone. This is a provider-specific kind of thought process. I personally, it depends on how low your testosterone is. If it's very low, I'm going to fix the testosterone so you can fix the other stuff too easier. No shade in this case if someone does something a little differently because they're more conservative, different styles of practice. If your LH is very high, that means your brain is screaming at your body to make more testosterone and your machinery downstairs is not listening to that message. This typically means you may have problems with testicular function. Have you had issues with fertility in the past? They tend to go together. So, if you have high LH, feel around downstairs and see if you have a lump on one of your testicles. If you do, that may actually be what's called a varicocele. This is an enlarged blood vessel. It raises the temperature of them. They don't like that. That's why they're not in our bodies. When the temperature gets too high, they function worse. They don't make sperm as well. They don't make testosterone as well. Or you may not actually find a cause. Have you had a surgery down there? That can also be a trigger for this. In some cases, it's a genetic disorder called Klinefelter syndrome. That means you received XXY chromosomes from your parents, and because of that, you have some testicular issues that may make you infertile or have less fertility and low testosterone. When we see a high LH, it at least tells us where the problem more or less is coming from, below the waist. That's it for testing. Treatments. There are a few ways, and I'm going to be painting with a broad brush here, to bring up testosterone. If you want to maintain fertility, oftentimes this will include a medication like clomiphene or something fancier like gonadorelin or another one of the hormone that mimics what's coming from up here to tell down there to work a little harder. I'm going to say the fancier stuff for these subspecialists here. In most cases, your PCP is not going to be doing something like that. I don't do it too much in the practice. So let's focus on what we hear most likely see. So the more common one is either going to be HCG or clomiphene. HCG is essentially just a hormonal analog, so a cousin to that LH. They tell the testes to make more testosterone. There you go. By doing so, you're not shutting down production, unlike, we'll get this later, with testosterone. By giving LH, everything stays functioning, and so when you stop it, you don't have infertility risks, decreased function, all that stuff. That's one of the good parts about HCG. One of the bad parts, it's tough to get compounded and it can be kind of expensive if your insurance doesn't cover it. So that's why a lot of us use clomiphene. Clomiphene has a mixed reputation. It originally surfaced as a fertility medication for women, and men use it off-label a lot of times because it kind of works pretty well for us too. However, the devil's in the details. It works as a selective estrogen receptor modulator, or in other words, it binds to those estrogen receptors and blocks them. By blocking those estrogen receptors in the hypothalamus, if you remember, your hypothalamus gets panicky, tells the pituitary to raise that luteinizing hormone output, and by doing so, testosterone goes up. When testosterone goes up, estrogen goes up. That sounds delightful. However, remember that the testosterone benefits also come from the rise in estrogen. And if you're blocking those receptors, you're going to miss out on those benefits. That's a big problem I have. I see this a ton, where somebody who wants to maintain fertility is prescribed clomiphene daily. You're going to get your numbers up. You're not going to feel much better. Instead, I usually do a pulsatile style, where it's going to be a dose every couple of days and not the max dose. I want to bring those numbers up, and if they don't come up enough, then you add a little testosterone. That way you maintain fertility with the clomiphene, but you get the numbers up and you have free receptors to which that estrogen can bind. Here's a fun fact about clomiphene that I only learned by doing a little bit of homework that wasn't assigned to me. There are studies on one of the two mirror images of it. So clomiphene is a mix of zooclomiphene and N-clomiphene. N-clomiphene was pursued as a novel treatment for these sorts of issues in men. It was abandoned during the trials, probably because of inadequate efficacy compared to what we had already out there or whatever. In some of those studies, however, they found that IGF-1 levels were decreased significantly, 50%. What is IGF-1? That is the protein after growth hormone binds to the growth hormone receptor. So essentially, we probably saw decreased growth hormone output because of clomiphene. So if you take it, you're going to lose out on the benefits of growth hormone by itself. This is kind of a problem because growth hormone is really important for deep sleep. So when you suppress that, you may have worse sleep because of it. You also might have worse sleep because clomiphene may give you hot flashes. So whenever I prescribe clomiphene, if I have the option, I may recommend low doses of sermorelin to keep those growth hormone levels up in the middle of the night so you can sleep and recover well. Here's a fun fact. Another problem with clomiphene is it may cause cataracts. So that's why we don't use it for long-term purposes. Also, we use it at the lower doses that we can get away with. I use doses of 25 milligrams every couple of days because that 25 milligrams is going to be half and half, essentially, of zooclomiphene and N-clomiphene. N-clomiphene at 12.5 milligrams is a very effective dose. It has a short half-life, and so by doing those pulsatile dosing schedules, you end up actually having time for those receptors to receive the appropriate stimulation. They're not blocked all the time. Otherwise, you may have mood issues, inadequate benefit in terms of erectile function, and risk for tendon injuries because estrogen is really important for tendon health. Okay. Testosterone now. Testosterone, most people are using testosterone cypionate. That is the only form that I have experience with, honestly, because that is what we use in my practice and we use in some of the subcontracting work that I do. I can deal with this stuff in my sleep at this point. Anyone who doses it once per week is setting you up for a whipsaw effect because it does not have a long enough half-life for this. So instead, twice per week is my minimum. You get 2 little bumps, you stay in range better, and you can get away with a lower total weekly dose than you would have for a once a week dosing. So you can have lower doses and better outcomes. By having a shorter spike, you also have fewer side effects because a lot of the side effects come from the total weekly as well as the height of the spike of testosterone. When you divide those doses, you don't see the same excessive red blood cell production. That could be a sign that your dose might be too high. You have less conversion to estrogen. You have less suppression of that luteinizing hormone. It is just better. And you feel better because you have stable levels. Technically, if you want to be the most physiologic, so the most like your normal system, you're going to do multiple times a week, but there's a diminishing returns, and you're tired of stabbing yourself with a needle that's not an insulin-sized needle. Testosterone is kind of thick, so you need a thicker needle. Still pretty small, but not the most fun to do if you're doing it, daily or every couple of days. So for most, twice per week is fine. Often I see doses, big round numbers, 200 milligrams, 150 milligrams, whatever. In most cases, you don't need to go that high. For an average sized person with average relatively low testosterone, I often start around 50 or 60 milligrams twice per week. This is usually pretty darn good. The other piece of this too is we don't have data to say what happens when you take somebody from a free testosterone of 5 or 6 to 15 or 16. Probably okay. We can track your hematocrit, so your blood cell counts. You can track your cholesterol. You can track your blood pressure. You can track your estrogen and just see. Are any of these alarm bells going off that your dose is too high? If not, and your PSA doesn't go up, you have no reason to think bad stuff is happening, at least in the short term. And if you're using this to become more active in the gym and respond better to that gym activity, it's probably a net benefit, but this is an individual discussion between you and your doctor. This is not medical advice. Okay, there are other forms of testosterone, a bunch of other ones. Again, those have different half-lives, different use cases. They're less common. I don't personally use them just because when you got something that works really well, why complicate things? Where to inject the dose? We used to always do it in the muscle. That always kind of seemed weird to me. Testosterone is fat soluble. Why would we put it in the muscle? It's absorbed faster in the muscle. Why would you put it in the muscle? Wouldn't you want something smoother that is less foreign to the tissue? So I do a sub-Q, the smaller needle then too, just like an insulin or Ozempic. Pinch some skin right here. Nice and easy. No problems. For most people, this is the best way to do it. Back to that anastrozole. So the estrogen blocker everyone's going to prescribe is going to be anastrozole or Arimidex. If you need it, use the lowest dose that you can get away with. Usually it's 0.5 milligrams once or twice per week. If someone starts out with me and they already have high estrogen and maybe some side effects, I will usually start them on it and then plan to wean them off in 3 months if their levels are reasonable still. It's that easy. Not that big of a deal. When it comes to other problems with male health, that's kind of along the same lines. If you have erectile problems, I'm a big fan of low dose daily tadalafil. 5 milligrams. That's Cialis generic. Why is it good? Because it's got a long half-life, unlike Viagra. So you can keep the pipes open and maintain blood flow to the erectile tissues all the time. This keeps them healthier because the pipes are open. You don't have to open and close them, in the moment, and then less perfusion, less blood flow the rest of the time. And you also can take it before the gym. This gives you a little bit of a pump in the gym. Kind of a fun fact, and a little off-label usage there. Don't need to spend money on that pre-workout for the pump. You can just take your Cialis, then have the benefit there, and wherever else. I don't know. There are studies combining Cialis and PT141. It's a peptide therapy. The branded version is called Vyleesi. It is for women for hypoactive sexuality disorder. In men, it seems to work just as well, but we didn't really pursue it for that in the FDA. So it is not FDA approved for men, but it is available in the peptide circles as PT141. It's a nasal spray. It's got a cool history. It was developed by accident when they're trying to find something, I think, for tanning purposes. Because it is a derivative of that medication, and it's called bremelanotide. So melanin, that whole pathway. It binds to receptors in the hypothalamus. When paired with Cialis, it is better than either alone. It does not work for everybody. Has side effects commonly of nausea and headache, and also a psychological dependence, because you think that you can't function without it if you use it too much. Anecdotal, but seen it. Testosterone is not that complicated for most people, yet I see it overcomplicated all the time. So we'll do one quick case. Say you're someone like me, 37 years old. Say I have issues with fertility and low testosterone. Want to have kids still, whatever. Say my testosterone is a free testosterone of 5. I'm 6 foot, about 195. We'll say that I would get a dose for myself. My starting point would be clomiphene 25 milligrams 2 to 3 times per week with sub-Q testosterone 50 milligrams twice per week as well. If I'm having erectile issues, low dose daily Cialis, or people use it off-label, but that would be irresponsible. I certainly don't do that before my gym trips. My estrogen's fine, would not be on an anastrozole. In fact, since I'm training for a powerlifting competition, that'll be a different video one day, would not want something that's going to cause those problems. Now, for the clomiphene, that might cause problems with sleeping. I don't want to have sleeping problems. Also, training for powerlifting competition. So, low dose Simorelin, about 200 micrograms. Take that on days where I'm taking my clomiphene dose. Problem solved. 2 benefits. Look into Simorelin. The studies were actually done on higher doses and had some interesting effects on muscle mass. I'll probably cover that in a different video another day. Hope you found this helpful. We got a really cool series coming out soon about cancer rehabilitation. That is where a lot of my practice is, and that one is going to be very, very useful for anybody who has a family member, themselves, starting a battle with cancer. Rehabilitation is the future of my field, physical medicine rehabilitation and metabolic medicine. I'm board certified in obesity medicine and PM&R. And it is how we're going to have better outcomes at lower costs and fewer side effects along the way. That's going to be a cool video. Check it out. In the meantime, thanks for watching. This is cool.